We're here. Now, a couple of things. I just sent you, we'll probably just introduce it today, the autonomic nervous system, which is really our last topic for discussion. So I just sent that along earlier to this group this morning. That's chapter 14. It's a very good ending chapter because it ties everything together. I'm doing spinal cord this morning. We're going to go through it. I'm going to highlight and tell you pretty much exactly what you need to know going forward for the exam. Because, I mean, it's something you probably should have covered more of it in lab, but I realized the accelerated lab played a role. This type of stuff. I sent you some emails regarding it. So this is RE final exam. A lot of people in this class have done fairly well. And I mean, if you're satisfied with your grade as it is, you're under no obligation. I said we can drop the lowest grade. Never done that before, but it doesn't matter. If you want to take the final and if you bomb it, we drop that grade. So it's non-jeopardy. If you have a grade that you want for instance, take this example. If you've got, let's say you started with a C+ and did progressively better, B- and an A on the last one. If you add up the quality points, C+ 2.33, B- 2.67, A 4.0, that would be add them up, that's 9 points divided by 3. You got a 3.0, that's B. Let's say that's your grade. I mean, if you want to take the final and see if you can bump that up to a B+ or an A-, okay, good for you. And I mean, if all of a sudden you're just overwhelmed with other finals and you take it anyway and you get another seat, we'll throw out whatever the lowest grade is. So it will never be any lower than what it would be going in. Does that make sense? It's up to you. All I ask is that you let me know. Also, I have 5 different openings for final exams. When is this one? Do you recall? I sent you an email with it. Thursday? Is it with the Thursday and the 10:30? Yeah. I'm giving exams. I got 3 on Wednesday. I have one on the 10:30 on Thursday, and on Friday I have the last exam at 1 o'clock with my group that comes in here at noon. Doesn't matter to me. I just need you. For instance, you're at 10:30 on Thursday. You have first seating. If somebody from Friday, and I think that's the group that's going to be switching out a lot, wants to take it, then okay. If they wanted to take it with this period, it's fine. But understand that if you want to switch, whoever's period it is, if there's not an available seat for whatever reason. That's why I ask you, if you want, let me know if you don't want to take it, and also let me know if you want to take it at a different time. I'm good with that. But I have to make sure I have enough seats. It's only going to be about 70 questions, 65, 70, same format. It's no different than any other exam. I sent study guides and sent recordings and blah, 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 without going crazy about that again. Okay. That's what I need you to know. But it's important that you let me know what you're doing to do it. I have no problem with the choice is yours, certainly. So that's out of the way. Bless you. So everybody, you kind of know from where you're going and what you're doing. Very good. So we're going to begin here with this last material that is on, and this is where I'm going to conclude. I want to go over the spinal cord because I felt maybe you should have had some of that previously, but I understand the limitations of what the lab was like. And again, there's next term for all of you in AP2, it's going to be normal, whatever that is. More important because I'm not teaching. That'll make it normal for you, not for me, but for you. Moving on. The spinal cord. Well, I sent you information over the break. And I went over the meninges or meningeal layers. Those are the coverings around the central nervous system, the brain, and the spinal cord. This is really a significant aspect. The spinal cord is very simplistic. It's basically a relay center. It sends signals out to your extremities and the rest of your body, and it brings signals in. Okay? That's really what it does. There's no processing per se. There's no cognitive ability for it whatsoever. It's basically a relay center. It involves reflexes, fine. We don't have any control over those. We can override them, but we don't have any conscious control, say, or subconscious control rather over them. Okay? But the significant difference is the way the codings are anatomically. And because of that, it permits us the luxury of doing an extraordinarily important diagnostic test. Fancy name is spinal centesis, CENTESIS, which you don't have to know. It's a puncture. So we can do what's called a lumbar puncture, or as many people call it, a spinal tap, to be able to pull out, you're going to see slides about that shortly, some cerebrospinal fluid and examine it. And why that is so terribly important is it gives us a rapid diagnosis if someone potentially has bacterial meningitis, which if you don't treat right now, they could probably die. That's why that test is so important. Okay, I didn't tell the other group because I like you better. Save maybe one or two individuals sitting in front. Joking. This is what you used to do at Children's Hospital. Little kid comes in with 104 temperature. Okay, what's the first thing they do? Urine sample. Because of a baby, because they can't very well tell you where it's hurting and stuff. They have a fever of unknown origin. Urine's relatively easy to collect. You can tell if it's a urinary tract infection. We have our diagnosis, antibiotics, happy day, and send them home. Suppose that doesn't give you the information. Next thing they do, before they do a blood test, next thing you do, chest x-ray. You want to do things that are non-invasive. If the chest x-ray doesn't point to pneumonia, which would be easy enough, it's very hard to listen to a chest accurately when the baby's screaming and crying. At that point, if they still don't have an answer, then they do the spinal tap. Because by that time, you'd better exclude bacterial meningitis. If not, that baby's probably not going to be living until tomorrow. That underscores the importance of this significant anatomical difference. The spinal cord, my bad illustration. I haven't found a good illustration. My wife has to clean. You get him on episode. I have never been described as cute. See, the two of us were described. I got the cute. So the cord, you're embarrassed. The cord terminates here at between L1 and L2. That's because the bones grow faster than the cord. Okay? The cord grows a little bit from the time of the baby. The bones grow along. So proportionately, there's a gap space. Okay? The termination of that cord ends in a tip that comes to not really a point, but it kind of comes to a gentle conical shape. And they called it the medullary cone, or conus medullaris. This is stuff you have to know. Termination of the cord. It's in L1 and L2, roughly between the first and second lumbar vertebrae. There's always that cord is tethered to the sacrum and the coccyx underneath it by a tiny connective tissue filament that's strong, and they named it because everything was in Latin. Terminal filament, we call it, or filum terminale. And what that is, and it's important because it holds the cord. When you're holding something, okay, really there's not a lot of give. The cord's thick. So if you stuck a needle and hit the cord where it's being held, you're likely damaging the cord, because it can damage. When we do a spinal tap, we go into an area below here, typically around between L3, typically it's L4, L5, because that's the biggest space. That's the area in this area, so I had L3, L4, this would be L5, and LBS over here. Nerves still come out. They come out below, and they'll go through those little openings, like foramina that you remember in the sacrum, interior, posterior, foramina in the sacrum, and through the typical intervertebral foramina L3 and L2, L3, L4, and L5. And because when they saw these nerves, took them all out, they spread them out, they look like a horse's tail. They're relatively big and large and equal on both sides. This is, they called it the cauda equina, which means horse's tail. That's the nomenclature associated with the cord. But the significant difference is that in the brain, the meninges basically have a couple, they're really not one layer. There's three different layers. The outermost layer is called the dura, for durable matter. The innermost layer, and when you dissected the sheep brain, you didn't see it because it adheres to the brain itself. It's called the pia, or soft or delicate matter. Where the cerebrospinal fluid is between the pia and the arachnoid. They call it arachnoid because there's little strands in between the pia and the arachnoid, and it looks like a spider web. So they call it the arachnoid. Subarachnoid is where the cerebrospinal fluid is. In the brain, you can't access it. The dura has little gaps where it's got a layer that adheres sometimes to the periosteum, to the internal structure or the internal periosteum of the cranial bones, and a space develops between that and certain areas of the brain. We call them a sinus. It's a point where the venous blood, and there's little overflow valves called arachnoid villi, which I described that to you in a recording, which are like overflow valves because we produce about a pint of cerebrospinal fluid every day, and we have to siphon it off and bring it back to the general circulation and recirculate it. It goes, and so the veins absorb it in these widened areas called venous sinuses. You should go back and look at those slides. That they're the last third of 12C. In the spinal cord, they don't have that. It's very adherent. Now remember that as we move forward. So the cord begins obviously at the foramen magnum and ends at L1 or L2. Two-way communication, major reflexes, blah. Terrible illustration. Here's that little green guy, whatever color it is, that's the filum terminale. Here's the conus over here. You can't even make any, who would know that was a cauda equina? Okay. There's enlargements in the cervical area, back and forth communications from the upper extremity, and in the lumbar or lumbosacral area, back and forth communications. Basic anatomy. The big terms for you so far, the cauda, the filum, and the conus. So in general, the protection is bone, that vertebral arch. The series of those becomes the vertebral canal. Remember, there in all the vertebrae, they had an arch formed by, between the body and the spinous process and the pedicles and the lamina. Ringing a bell. The dura mater only has that one layer. It doesn't attach to the vertebrae. There's fat that surrounds it. Fat is a protective area. Fat's around your heart, fat's around your kidneys. Fat protects important structures, cushions. One of its many roles. This is the important area, and it's a reason why when you hear the term epidural, we associate it with what? Someone gets an epidural, what are they typically doing at the same time? They're giving birth, correct? So it's and it's not an anesthetic, it's an analgesic. Analgesia is relief of pain. Anesthetic is the absence of pain. They're injecting into the epidural fat, which has blood vessels and nerves and things like that, really a potent local anesthetic and some other material in it, and effectively, to some extent, it numbs the area, though don't ask my daughter about how effective it was. Okay, if it's given right, it's very effective. If it's not given right, not so good. Okay, when you're doing a spinal anesthetic, you have to inject directly into the cerebrospinal fluid. It is not something that people routinely do. I have never done it. I've never done either an epidural or a spinal. Those are people who have to be very, very rigorously trained, because if you mess up, you're going to paralyze somebody. And there they inject a specific kind of local anesthetic into the cerebrospinal fluid. By the way, they weight it so it doesn't go up. Okay, because if it goes up, it gets to the brain, and you don't want to anesthetize your brain, because then you'll stop functioning. Just little tidbits, none of which you have to know. I'm trying to give you some context. So the cerebrospinal fluid is in two areas. In the spinal cord, you're going to see the central canal. That's the continuation of the ventricles. that kind of starts in the medulla oblongata, goes all the way down to the bottom of the cord to the conus, and like always, the other area where we see cerebrospinal fluid, other than the ventricles and the central canal, is in the subarachnoid space. Remember, it's on the inside and the outside, so effectively the brain and the spinal cord, the central nervous system, are floating. Okay, so this is why you can do a lumbar puncture. We call this a catheter. It's a needle that's hollow, and it's got another needle inside. So we pierce it with a needle that stays in, and we would draw that. Same thing you would use for an IV. Okay. Generally, the sharp point of the needle that you would draw creates the opening, and then you have a hollow passageway. If it's in the right place. Now, an epidural would be here, comparatively easy, comparatively. But then you'd have to go take that needle through this needle through the connective tissue and make sure you get into this space. It's very difficult. Again, the idea of the phylum terminale, if something is tethered and you put a needle into it, it's not going to give. You could penetrate it. If you're doing it below that level, below L1 and L2, if you hit something firm, it's a nerve and it's not tethered, it can move. So you can feel it and go, uh-oh, I better move a little bit to one side or the other. And then you know you're in the space. How do you know you're in space? You pull that out and you get drops of fluid, which is relatively clear. It might start with a little blood. And you basically collect 3 sterile test tubes and send them off for analysis. That's how they do it. Super important test. So, moving on. So here's the conus, the phylum. What kind of helps, you'll see them, they're called denticulate ligaments. I'm not going to ask you about them. They're just basically look like little teeth, and they're sort of holding the nerves in place. Nerves are relatively complex. It's not like one nerve comes out of the spinal cord. They have what are called rootlets, ROOTLETS, tiny little roots that come together as a nerve. Okay, and it's why the guy had a disc that bulged 12 years ago. And this whole area is numb. Okay. I mean, originally it was pain, so it's clearly a sensory rootlet that was affected, but the damage was enough, whatever pressure was on it was enough to damage the part that produced general sensation. So I get on my hands and knees to do something, cleaning up after the dog, typically. Okay, he's a puker. He's got to stop eating his toys. And then I can't feel that. Doesn't mean I can't use it. It doesn't mean I'm not so much numb that I couldn't get a cut there and not feel it, but you get the idea. So it all depends on where they are. The spinal nerves are really peripheral nervous system. The only part you learned about my understanding so far are the cranial nerves. So we're not doing this. This is something you're going to start with in AP2. I'm going to let whoever's the instructors, I think there's at least 2, if not 3 of them, will be doing this. Okay, and that's it. Chorda equina, bad illustration. What it looks like in real life is here. So you can see it's relatively thick comparatively. Those are those little rootlets. And they come together and form the nerve. And you're going to see sensory fibers are coming in the back. Motor fibers are going out the front. Except we don't use back and front or anterior and posterior. The nervous system, we use older terminology, ventral and dorsal. Even though anterior and posterior work, these were the earliest areas, the brain and the spinal cord were the earliest areas described anatomically. So they used the older terms, ventral and dorsal. And there's a sulcus on the one in the back, doesn't matter. I'm not going to talk about the ganglion. Okay, again, that's peripheral nerve construction. It's there. Here is the conus. Here's the phylum terminale. Here you can see, and you can imagine when anatomists teased that out and spread them out on a table, they look like a horse's tail. Don't worry about that. And again, don't worry about these. The cord has these little clefts would be the way to describe them. I'm not doing that anatomically. And again, the central canal is filled with the cerebrospinal fluid, as is the subarachnoid space. That's consistent. Where's the spinal fluid found? Subarachnoid space, whether it's around the central nervous system, and also in the central canal and the ventricles. That's coming up on the test to know where the cerebrospinal and know about all those ventricles. Hopefully Monday we can dedicate the day for those who want to be here and are taking the exam to a review session. Hopefully we'll have time to do that. Here's what it looks like. Those are when they talk about the fissures that are there, you know. So here, this is a cervical vertebrae. You can tell by the bifid spinous process that's there. There's a transverse foramina, you know, cerebral artery. Remember that? See? Good-o. I'm happy. And so sensory are coming in posteriorly, motor are going out anteriorly, except we call them dorsal toward the back and ventral toward the front. Back and belly. What dorsal and ventral mean. There's the central canal. The gray matter are called horns. So that's a dorsal horn and a ventral horn. Anatomically, there's actually a little tiny lateral horn that you see, and we'll see it when we get to the next chapter. It's associated with sympathetic nerves in the thoracic and lumbar area. The white matter are called columns. So you have a dorsal column, a ventral column, and a lateral column. Orange for dark, gray matter, white columns. That's the part to remember. Trying to keep it relatively straightforward. These are the layers of the meningeal layers. The pia adheres directly. It's just like a thin film, so soft and delicate. The arachnoid is a little bit less distinguishable, but between, here's this subarachnoid space. So that's where the fluid is. And again, these are tiny little like gossamer strands that have spider web appearance both in the brain and the spinal cord. Hence its name looks like spider web. Arachnoid. And then lastly, the dura. And dura is strong. You and I could play tug of war with a piece of dura. I used to have one. Did I tell you I had a brain? I have a brain. I had a human brain and spinal cord that I got when I was teaching graduate neurology at Chatham. Oh, more than 20 years ago. And I had it in one of those big white cans that you see, those white plastic cans filled with formaldehyde. And I was adjuncting other schools. So I take it with me to show it. And one day my daughter, she's looking at the trunk of my car with her friends were outside. She's still in high school. She goes, "Dad, have you got a brain in your car?" I said, "Yes." Can we see it? It's the closest she got to college. Again, other than parties. You're looking at me like I'm telling you something that's not true. Believe me, it's true. Only arrested at one party. Just one. So taking a look, dorsal, ventral, lateral, only in that area. We'll get to it. The gray matter between them looks like a letter H. That's the gray commissure, a little bridge of gray matter enclosing the central canal. That's noteworthy. That's about it. Everything else here is very straightforward. You don't have to know those. Other than the things I've told you. I want you to be very clear because I don't want to burden you with this. The next chapter, the autonomic nervous system, is much more important. So with my graduate group, we see these. We go over all these things and what they're supposed to be. So I don't want you to have to worry about that. The white matter is like white matter. Projection fibers, commissural fibers, etc., etc. We already covered those. The white matter is mostly, obviously, myelinated. It's going to contain some non-myelinated fibers as well. And here's the names of the columns. You don't have to go any farther than, this is the old term in Latin, funiculi. You don't have to use that. Again, if you're going on to a graduate level eventually, that's the kind of stuff that you might come into contact with. They tend to use more traditional terminology. You saw that illustration before. So again, that's that central canal. There's that gray commissure. This is when they're showing that little sort of that sort of, as you can see, the so-called lateral horn. That's only involves the sympathetic and parasympathetic. We'll get there soon. They call these tracks that go up and down. The ones that are sensory are in blue. The ones that are motor in red. You don't have to know a lot about them. Bless you. This is the most of your sensory fibers. You can see there's a large amount. We get a lot of sensation in the spinal cord. All that stuff about balance and proprioceptors and general sensation that we talked about going up to the cerebellum, that has a lot to do with what's called the dorsal columns. That's why when there's diseases that affect that, it's very significant. Okay, for those taking micro with me, we'll learn about syphilis affects those. It's a venereal disease or sexually transmitted disease, still around, a little less common now as time has gone. And red is motor. So to give you some context, the ones that are important, the spinothalamics, sensory nerves typically are a 3-nerve circuit. The nerve that senses, oh, that was hot. The nerve that takes it up, the second nerve takes it up to the thalamus, and the third nerve directs it to the appropriate part of the brain. Okay, where are you supposed to get that? Burnt the tip of your finger. And it was your index finger was on your left hand. Okay. So we call them first, second, and third order nerves or neurons. You will see this. 3-nerve circuit sensory ending in the brain. That's called the spinothalamics, that sharp, dull, hot, cold, pain, all that stuff. The corticospinal or pyramidal tracts, we talked about the pyramids. In the anterior portion of the medulla oblongata, that's basically your brain telling this to move. It's a 2-nerve circuit. From your brain to the spinal cord is called the upper motor neuron. These terms are important. From the spinal cord out to the muscle, lower motor neuron. 2-nerve circuit. It could be, again, a 6'12" person. They're typically about 3 feet long. Brain to, let's say, going to your big toe. Brain to your lumbar sacral area to your big toe. So when we talk about this with regard to spinal cord trauma, this is kind of what happened when my disc bulged. A local injury, probably to one of those rootlets, caused damage. Paresthesia is a fancy term for sensations that should not be there. Mind numbness, your foot falling asleep, needles and pins, that type of stuff. We've all felt those things. Funny sensations that are really not what you're supposed to feel. They're very relevant down the road when you start learning about the thing called diabetic peripheral neuropathy. It's there. Paralysis is motor. So paresthesias are sensory. If you lose all of them, anesthesia, absence of sensation. Paralysis is motor. And again, they're going to talk about the 2 types of paralysis, flaccid and spastic. Basically, flaccid, the part going to the nerve or going to the muscle. It can be the nerve or it can be transmitting to the muscle. It's called flaccid paralysis. The muscle's not getting the stimulation, it atrophies. It begins to, if it's not being utilized, it begins to get smaller, thinner, if you will, and eventually turns fatty and deteriorates. The impulse, for whatever reason, does not reach the muscle from the spinal cord. Okay, and it atrophies. Spastic, talked about it before. The nerve going from your brain to your spinal cord, to that area, typically we see that in a stroke. What happens in a stroke, that nerve is damaged and it begins to produce glutamate. Glutamate is always excitatory in the system. And what happens, it begins to excite those muscles. The flexors are stronger than the extensors. They overpower them. And that's why you see people with flexion contractures. Everything we can do to stop that. So you have to brace people. It's part of rehabilitation. If you go into a field where there's rehabilitation involved, you'll learn all about that. So it's called spastic paralysis. That's there. Upper motor neuron is where it's damaged. Here it's lower motor neuron. The spinal nerves remain intact. The muscles continue to be stimulated. The muscles will often, and that's the idea of rehabilitation, because when these contractures can't be broken, now they've shortened permanently. The bones and the joints adapt to that position. We talked about that's called Wolff's Law. So you see all of these things. It's very difficult to rehabilitate. And so what happens, and this is a difference when we talk about Paraplegia means you're below the cervical area. The implication is that you've lost all or some of your function of the lower extremities. Basically, it implies torso, but mostly lower extremities. Quadriplegia is cervical area, that's both upper and lower extremities. And it's all a matter of degree. A lot of times people with, for instance, the typical cervical fracture in this area called hangman's fracture, where we don't see it too much with hanging, obviously. Not that we want to study that, but when someone falls off a horse, they're doing equestrics. And what happens, that's typically I saw one of those when we were in, because they had there was a race course that had equestrics outside of Philadelphia, and it was called Cherry Hill, New Jersey. And I was a student assigned to their orthopedic service. This gal fell off a horse, classic fracture there. And the treatment, it was called a halo. So you had to basically create like a metal halo and brace it to her head with a brace that they were going to wear. So it was pulling her neck as a form of traction. So we had that was eventually what was going to happen to her. She came into the emergency room. We had to wait for the neurosurgeon to come in to flip her, be able to turn her, basically to move her in such a way that she could be assessed properly neurologically. And there was like 10 of us holding specific areas, and it basically said, wait, the neurosurgeon is going to tell you exactly what to do. We had to wait for that and just hold her there and then finally move her in such a way that she could be assessed and treated. Because if you messed up, paralyzed for life. Crazy. But that's a very, very, and what compromises in the cervical area, when you learn about that, if you didn't in peripheral, it's called the phrenic nerve. It comes from that area, and phrenic, PHR, diaphragm, and they have respiratory failure. Famous late actor named Christopher Reeve, who played Superman back in the 70s and 80s, he succumbed eventually to that. He regained some digital function, but inevitably they succumbed to pneumonia because he was intubated for a long time. You learn about this in micro. All my micro students will. This is a classic disease that causes atrophy. It affects the nerve going to the muscle. We call the ventral horn cells. And typically they succumb to respiratory if they succumb. We are all immunized for this. We talk about the immunization because it was developed here in Pittsburgh by Jonas Salk. Eventually refined so we get differently. I'll go into the history of that. Nevertheless, I saw patients who were before that were affected. Polio is everywhere. Our longest serving president, 4 terms, thank you very much, Franklin Delano Roosevelt, contracted that before he became president. And he had fireside chats because he would be seated. When he addressed Congress, they didn't allow Congress to come in until he was already standing at the podium. He didn't want people to see that he was it doesn't affect mental capacity, but they didn't want to see he was weak. He was the president during World War II. They didn't want to perceive weakness. It's very common. He had, and the post-polio syndrome, look up post-polio syndrome, the contractures and irregularities. And I saw a lot of those in my practice. And this is very famous. So stroke is the upper motor neuron affliction. The lower motor neuron affliction is polio would be a common part of it. And this is both. Lou Gehrig's disease, called amyotrophic lateral sclerosis. Famously, Stephen Hawking had this disease. And the tragedy of it is you begin to lose control of your voluntary muscles, but your mind is unaffected. And so, perfectly cogent, all of these, and you see a lot, unfortunately, it's affected a lot of people. There's an actor now who was on Grey's Anatomy, Eric something, and my wife's a big Grey's Anatomy. He was Dr. McSteamy, not McDreamy. He's got it. Now he's confined into a wheelchair. So, no Grey's Anatomy fan? You know the guy I'm talking about? So he's got it now. He's the most famous guy having it now. Stephen Hawking, who was hardly as dreamy. It's all of that. There was a great movie with Eddie Redmayne winning an Academy Award for that. And it was named after Lou Gehrig, a famous baseball player with the Yankees, who had never missed a game, 2,190 games, until it was surpassed by the guy from the Orioles, Cal Ripken Jr. And at that point, all of a sudden, and he died a couple of years later, there was no treatment. And the treatment is not terribly rewarding. And again, it involves this glutamate. Again, plays a role in it. Another word you should remember is decussation. That's where the fibers cross over. Even though it's crossover would be the name, please remember decussation for where things cross over. And then you can look through this as easily as I can explain it. Again, the first order sensation coming in. Second order effectively takes it to the thalamus for our purposes. We're not going to specifics of different pathways like spinocerebellar or things like that. Third order, and this is the job of the thalamus, sorts, edits, relays, sends it to the appropriate area of the brain. Okay, we don't want to do this. Again, the spinothalamics, pain, temperature, again, 3 nerve circuits. Even though it says thalamus, it doesn't end there. It's got to send it to the brain. And they just show you some pictures, and that's it. Nothing else to be not worried about, direct or indirect. Any along those lines. Spinal damage, which I did skip. There's 2 types of damage. Whether it's in the spinal cord or the brain, we have both names, concussions and contusions. Concussions imply that it's not necessarily permanent. Contusions suggest that there's permanent damage, bruising, whatever you want to describe it. So, I mean, it's a fine line between them. A lot of times we'll see something, I skip by it, they're called spinal shock. You'll see somebody in an athletic event, their head gets hit for some reason, and they're, oh my God, they can't move their extremities. Everybody comes out. They very carefully today put them on a board, secure their head and neck, just like I was saying before we saw in the emergency room. Because heaven forbid, if it moves, it could cause serious damage. And they're not moving their extremities. Everybody's, oh my goodness. And they hear, oh, that later that evening in the hospital, maybe days later, they have full movement of their extremities. Everybody's delighted. That's spinal shock. Sometimes you have to actually chill the body to prevent that swelling from increasing, and we use various kinds of steroids to stop that. Okay, so there's a variety of treatments to try to get the swelling to go down. The shock during that period where it's in shock comes back, and that's been a lot. The football player here at the Steelers who didn't have that benefit, unfortunately, was Ryan Shazier, maybe 6-7 years ago. He tackled with his head in a bad position. It was a bad tackle. And he ended up immediately losing function of his, I think it was mostly lower extremities that were there. But initially the shock probably was both. He never came back to play. He couldn't. So he had permanent. He still, you can see he was damaged. There's parts that were damaged permanently, but he's able to walk and move around again. Although certainly not. I had students ask me, "Will you think over to play football?" And the answer was no. You knew there was permanent. And liability-wise, no doctor would certify that they were able to play. Nobody would take the chance. And so that's all part of where this comes from, which leads us to the last topic for today as a brief introduction. I just sent this to you. The autonomic nervous system, if you want to say automatic, go ahead and say it. I mean, involuntary nervous system or general visceral, I never use. It's a wonderful way to end the term, because this is homeostasis 101. Everything we talked about homeostasis, this is the system. The system is relatively easy. It's not hard to understand anatomically. You're going to soon see a little confusing terminology there. Going through either the brain or the spinal cord, nerve circuit. That we don't have first and second order. This is a motor. You have pre-ganglionic and post-ganglionic. Pre-ganglionic comes from one part of the brain, the spinal cord. ganglion is a cluster of cell bodies that's outside of the brain and the spinal cord. And the postganglionic nerve goes to wherever the target organ or gland that's involved. You're going to see this repetitively. It gets a good time to get used to knowing the terminology, pre and post ganglionic, because it's really important, because you're going to, this leads so much for many of you, particularly the ones going in the clinical fields. The vast majority of our medications to address problems we use to impact this system, since we can't control it ourselves. So there are two branches to this system, as you will see. It's strictly a motor system. I mean, obviously sensory input defines how you respond, but the responses are either the sympathetic, known as the action division, and the parasympathetic, which is sort of, we call it the rest and digest. And I've given the same example over and over. What happens? That idiot, you're driving a car. That's pure sympathetic. We call it fight or flight. If you know what goes on there, you'll know exactly how both systems impact you. Fight or flight, I'm going to go over it a bunch of times. Eyes wide open, rapid heart rate, rapid breathing, respiratory passageways wide open, secretions dry up, because that way the secretions don't dry up, you can't breathe very effectively. Again, your heart's racing, your digestive and urinary tracts slow down to minimal activity. All the blood flow goes from either to the heart or to skeletal muscles, so you can fight or run away. Act very, very quickly. That's sympathetic. Just the fight or flight is the closest thing to pure sympathetic. And the opposite of all of that, what happens when you're sitting here now? Your eyes are relatively constricted, your heart's at a normal pace, your breathing is normal, your respiratory passageways are typically normal. The quarter or more of your blood flow is going to your internal viscera. It's going to your genitourinary and digestive system. That's what happens. You're going to see that. It's dramatic. They work in concert. When our heart starts to accelerate for whatever reason, you sit down, you're going to take that test, your heart's going to accelerate. When you're done with it, typically you start to calm down. Like that. When they play like that way, they're the perfect sort of yin and yang, that sort of biological tug of war that maintains homeostasis. And it's so important. And the vast majority of medicines get terms. Sympathetic. We have medicines we call sympathomimetic. They mimic the sympathetic system. These are terms you're going to get in pharmacology, many of them. Or if you have patients with medications, you have to understand. Someone will say sympatholytic. They block. And then there's parasympathomimetic and parasympatholytic. We will go over this in the next couple of classes that are there. You're going to learn about different receptors, because they only make the neurotransmitters are effectively acetylcholine or norepinephrine. So norepinephrine, another name for that was noradrenaline. You might remember me saying that. And so you're going to have cholinergics, nerves, receptors that respond to acetylcholine, and adrenergics, nerves that respond to adrenaline or adrenaline-like substances. You can see all of it. It's part of the reason why everybody knows somebody's walking around with an EpiPen. There's a reason we have that EpiPen. You're going to learn about that. Because the EpiPen basically is immediate adrenergic stimulation. Because of that, it dilates your bronchi so people can breathe when they're in asthmatic crisis or something a la anaphylactic shock. Okay? This is where it all kind of comes to the party. We learn about that. So in this particular thing, we're going to see what it affects. We're going to look at the pathways a little bit and the target organs, and particularly those neurotransmitters, because a lot of the pharmacology, you're going to hear things like alpha 1s and alpha 2s and beta 1s and beta 2s. And I might as well give you a heads up on them now. That one with the EpiPen's beta 2 pathway. So the somatic nervous system, skeletal muscles, autonomic nervous system, all the stuff we can't control. The heart, smooth muscle, all those hollow tubes, blood vessels, respiratory passageways, genitourinary, digestive passageways. glands. And here are those terms, preganglionic and postganglionic. You don't have to read through that so much. So the autonomic nervous system, we're going to talk about the different neurotransmitters that are there. I stopped here with the other class, so I don't want to start with you because it's just too cumbersome now to go into it. We're going to start here on Wednesday. Thank you very much. Do let me know what your plans are vis-a-vis the final. And if you're not taking the final, you should certainly be here for this. Thank you. See you all Wednesday.